What do you mean by interprofessional education? Actually, interprofessional education is designed to promote teamwork among different health professions and is defined to two or more professions learn from each other to improve the collaborations and the quality of care. WHO also acknowledged interprofessional education as an important aspect of healthcare in 1972. And it is also noted that there is an increased trend towards the multi-professional teamwork in healthcare, supported by an increase in body of evidence. Interprofessional education in Sri Lanka. As you know, interprofessional education to the Sri Lanka is new, because earlier all the health professional institutions, MLS, nursing, radiography, and all the other paramedics and medical, all the separate professions learn their separate education, separate institution. There is no any institutions, these all the professions learn under one roof. So this is new to Sri Lanka. And the first photograph, all the photographs are in Sri Lankan photograph. First one, medical student, physiotherapy student, nursing students are in the photograph. And second one, can you identify? Chula sir is there. The photograph in the Faculty of Allied Health Sciences, which was established in the older dental faculty. This picture also I got from the Faculty of Allied Health Sciences, University of Perera. They are integrated learning, small group discussion. And the history. The history of the Allied Health Sciences professions, these degree courses are still in the developmental phase in Sri Lanka. The University Grant Commission began the following degrees in 2005. Accordingly, 5 degree courses, namely 4-year BSc degree program for the nursing, pharmacy, radiography, physiotherapy, and medical laboratory sciences were commenced in the University of Perera. At the same time, the later some other university also commenced. As example, University of Colombo commenced BSc Physiotherapy degree program, and Sri Jayawardena University commenced MLS nursing and the pharmacy program, and Ruhun also commenced nursing program. And now last year in 2013, General Sir John Kathalawala University also commenced all the 5 degrees. So this is a new era for the Sri Lanka interprofessional education. But this is not new for the Western countries. This is all well established in the Australia, Canada, and all the other Western countries. But for the Asian countries, interprofessional education not that much of develops. It is in the developmental phase. The aim of my study in this paper to explore the perceptions on teaching learning methods of interprofessional education among pre-registration students in different health professions in Sri Lanka. The long-term goal of my paper to introduce the context-appropriate interprofessional education into the health profession curricula in Sri Lanka. The methods. This is a cross-sectional study. Study populations who have had prior clinical training for a period of 1 year, as they would have experienced interprofessional practice and interprofessional learning opportunities by then, from 8 health professional groups: medicine, physiotherapy, nursing diploma, nursing degree, medical laboratory science, pharmacy, audiology, speech and language therapy at different education institutions. Medicine and the physiotherapy students were selected in Colombo University. Nursing diploma student was selected in NTS Colombo, and degree student, nursing student was selected in University of Jayawardena. Pharmacy student was selected in University of Sri Jayawardena. Audiology, speech and language therapy was selected in Ragama medical faculty. Data collection instrument. The self-administered questionnaire, which is considered validated 19 items as stipulated in readiness for interprofessional learning scale, was used, and together list of teaching learning methods. These methods have been discussed in IPE literature, were considered in this study. My paper basically based on the teaching learning methods. I did not concern in the Ripple scale because I have already published in that paper. In this paper, I just only because of the teaching learning methods of the interprofessional education, those were discussed, and I use IPE literature, and with medical education is in senior lecturers, I have formed the teaching learning method questionnaire. List of teaching learning methods were lectures, demonstrations, small group discussion, work-based tasks at the ward, role plays and simulation-based learning session, and integrated ward rounds. Methods. The questionnaire was piloted and then administered to 686 students of the different health professions. The data was entered and analyzed using SPSS. ANOVA and Scotch post hoc test was used to compare the response of the different health profession groups. The response rate for my survey was 84%. I got the good response rate. Medical student responded 80%, nursing student 80%, physiotherapy student 93%, pharmacy student 90%, nursing degree student 76%, medical laboratory student 90%, audiology student 72%, speech and language therapy 70%. In my study, female students were 73%, male student 24%. Only 18.90 of the students reported the previous IPE experience. Actually, they are not awareness of the interprofessional education, formally exposed, informal exposed to the interprofessional education. Medicine were 23, nursing 12%, physiotherapy 14.54%, pharmacy 12.96%, nursing degree 52%, MLS 11%, audiology 41%, speech and language therapy 9.52%. Nursing degree students reported highest informal interprofessional education experience because they are involved in more situation, clinical situation, theatre situation, so they have faced more rate. Speech and language therapy student rated low scores because they are not directly involved in with the interprofessional education situations. Interprofessional education previous experience and the perceptions of the interprofessional education, there is no any relationship between the their experience and the perception. They are informally exposed to the interprofessional education. Different teaching learning methods that may be used for the interprofessional education. So in this table, the mean scores were considered for the medicine, nursing, physiotherapy, pharmacy, nursing degree, MLS, audiology, speech therapy students. Highest rate of teaching learning method was work-based tasks at the wards. Lowest rated teaching learning method was lectures. Actually, interprofessional education is not all the students learn under one roof. They have to integrate it with G-Tajers. So we can think, students know work-based tasks at the ward is the best teaching learning methods. And the lectures under one roof, just listen to the lecturer is not the interprofessional education. But I also consider that it as a method, but it get lowest rate. Highest rated teaching learning method among different professions. Medicine rated work-based tasks at the ward round is the best teaching learning methods can be used in the IPE. Nursing diploma student rated demonstration, physiotherapy, pharmacy, nursing, MLS, audiology, speech therapy student rated work-based tasks at the ward is the best teaching learning method can be used in the IPE. Medical MLS audiology student rated some low values for the class-based method compared to others, while all groups rated higher rated for the ward-based method. And also, I gave a chance to the students to mention their suggestions for my questionnaire. They have suggested several other teaching learning methods. They suggested workshop and presentation, community-based field trip, what classes, problem-based learning, what round with all the health professional student, group discussion. They have suggested these also can be used to use as teaching learning methods to improve the interprofessional education among health professional students in Sri Lanka. I also got the literature findings. Health professional students rated higher values for the ward-based teaching learning methods and low rate for the class-based teaching learning method. Medical students rated low values for the class-based activities in my study. Similar findings were shown in the McDonald's in 1996 that medical professions are reluctant to participate in certain education activities such as role play, small group problem-based learning and practical experiences. And most of the students in my study rated traditional lectures are the less important to improve the IPE. Activities and problem-based learning was suggested to improve the IPE. Several studies had shown in pre-BL is an structured education activity, usually employing case presentation as the stimulus to learning, and this approach which helps students learn to listen to each other and to collaborate as they work to resolve the problem. Problem-based learning is the best teaching learning methods which is identified in the literature. Conclusion is all the students group identify all methods as somewhat effective, but however all groups rated clinical teaching method higher than class-based method. Students perceive that ward rounds and work-based tasks in wards are effective to large extent for achieving the aims of IPE, while lectures were rated the lowest rate. Conclusion, I suggested that without above interactive learning tools, practice in IPE would be difficult. This study indicates important consideration in customizing IPE experience to the Sri Lankan healthcare context, and that certain focused approaches need to be developed for IPE in Sri Lanka. Thank you.
Okay. Thank you, Ms. Perera, for that very interesting presentation. I think we'll move on to the next one. Diabetic nephropathy among the patients in the diabetic clinic of the Colombo South Teaching Hospital. The presenting author is Ms. M.W.N. Nisansala. She is a nursing officer at the General Hospital Sri Jayawardhanapura. So may I invite Ms. Nisansala to make a presentation?
Thank you, Chairperson. Ladies and gentlemen, my topic for today is diabetic neuropathy among the patients attending the diabetic clinic of the Colombo South Teaching Hospital. Diabetic neuropathy is the presence of signs and symptoms of peripheral nerve dysfunction in people with diabetes after exclusion of other causes. Diabetic neuropathy is the most common complication of diabetes, and it presents in both types of diabetes. Peripheral neuropathy is associated with increased foot ulceration and lower limb amputation. Therefore, early diagnosis is vital. Objectives of my study is to determine the proportion of diabetic neuropathy among the patients presenting to the diabetic clinic of the Colombo South Teaching Hospital, to assess their knowledge on prevention of foot diseases, and to determine the association between the glycemic control and diabetic neuropathy. We conducted descriptive cross-sectional study among 384 subjects diagnosed with type 2 diabetes mellitus, attending to the diabetic clinic of the Colombo South Teaching Hospital. We used systematic random sampling method, and these are our inclusion and exclusion criteria. We used interviewer administered questionnaire and examination as our data collection method. It consisted of 3 sections. Section A is socio-personal data and body composition data. Section B is the most important part of our questionnaire. It consisted of Michigan Neuropathy Screening Instrument, Diabetic Neuropathy Index, and the monofilament test. Section C is questionnaire to assess the foot care practices, and we use the SPSS 16 version as our data analysis source. Michigan Neuropathy Screening Instrument consisted of 15 questions which assess the following parameters, and Diabetic Neuropathy Index included in examination of feet assess the following parameters. Monofilament test was conducted in 10 points in each foot on the dorsal and plant aspects of each foot. Criteria for diagnosis of diabetic neuropathy: score of more than 4 in the Michigan Neuropathy Screening Instrument questionnaire, score of more than 2.5 in the Diabetic Neuropathy Index, and the less than 7 responses from each foot in monofilament test. Diabetic neuropathy was confirmed by a positive score of 2 of the above 3 tests. Mean baseline characteristics of the population. There are more females in than the males in our study. BMI was significantly higher among the female more than males, but the waist-hip ratio is significantly lower among the females than males. Clinical examination test results of the population. Over 65% of the population has had the positive Michigan Neuropathy Screening Instrument score. 45% of the population had the 2 test positive. That means we diagnosed 45.6% of the population as they are having diabetic neuropathy. But only 16% of the patients had been previously diagnosed with neuropathy according to their clinical records. When we compared neuropathy group with the non-neuropathy group, duration of diabetes and the postprandial blood sugar levels significantly higher among the neuropathy group when compared with the non-neuropathy group. We assess the association between neuropathy score and some selected parameters. According to that, duration of diabetes and the postprandial blood sugar levels correlated with the neuropathy. Good foot care practices scored more than 12 points in the foot care questionnaire. 37% of the study population had good foot care practices. Good foot care practices were better amongst the females more than the males in our study. Conclusions of our study: Michigan Neuropathy Screening Instrument and the Diabetic Neuropathy Index were the most useful in the diagnosis of diabetic neuropathy. The study showed higher frequency of neuropathy than the previous studies conducted in Sri Lanka. Study highlights that foot care practices are not adequate amongst the study subjects. The neuropathy indices correlated with postprandial blood sugar level. Therefore, regular measurements of postprandial blood sugar should be implemented among the diabetic patients. Recommendations of our study: Michigan Neuropathy Screening Instrument can be used as a screening tool in the outpatient setting in Sri Lanka. As Michigan Neuropathy Screening Instrument is a brief screening instrument, several diabetic neuropathy screening trained nurses should be available to regularly screen the diabetic patients in the diabetic clinic. All diabetic patients should be screened annually for neuropathy in Sri Lanka as recommended by the American Diabetes Association. Health education programs for diabetic patients should be conducted to increase the awareness of high prevalence of the diabetic neuropathy and about the proper foot care practices. The study can be further extended to assess nerve conduction study of both lower limbs for earlier diagnosis. I gratefully acknowledge the academic staff of BSc Nursing program of my faculty and consultant endocrinologist and all the nursing staff of the diabetic clinic of the Colombo South Teaching Hospital, and finally all the participants. These are some of my references. Thank you.
Thank you very much, Ms. Ansala, for that very interesting presentation on an important area which is often neglected in diabetic care. So thank you very much. Now we'll move on to the next presentation, which is on awareness, associated factors, practices and myths regarding acne among the students of University of Sri Jayawardenepura. The presenting author is Ms. A.D.P. Veeravardhana. She is a lecturer in the Department of Nursing and Midwifery, Faculty of Allied Health Sciences of the Sir John Kottalawala Defence University, and her research interests are in community nursing and prevailing health problems in society. Over to you, Ms. Ansala.
Good morning.
Ms. Veeravardhana.
Good morning, everyone. Thank you, Chairperson ma'am. So today I'm going to conduct this presentation regarding my research, which we conducted in awareness, associated factors, practices and myths regarding acne among the university students of University of Sri Jayawardenepura. So first of all, let's see what is acne. Acne is often mostly a common skin condition, usually beginning in adolescence, but resolving spontaneously, affecting about 80% of persons aged 11 to 30 years. And majority of them are adolescents at the age when they have undergone maximum physical and social psychological changes of their lives. So there is a very bad impact on them also, because that is the age that they concern more about their appearance. So acne can become a great psychological problem to them. I'm very interested in doing this research regarding this. And this is a picture with acne, and doctors describe as acne is a chronic inflammatory disease which causes pilosebaceous units, producing comedones, papules, pustules, cysts and scars. And in this picture you can see these stages of acne formation. And the last stage is the most critical phase, where suburative pustules are formed. And even though the exact cause of acne is still unknown, because it is multifactorial, but according to the literature that we have searched all over the world, we have read in 20 researches regarding acne and its associated factors. So we have recognized that heredity, hormones, skin condition, environmental factors, dietary habits, stress and cosmetics can cause acne most of the time. And it was found also that there is a positive correlation between dietary habits and increasing risk for acne in a study done in Turkey. And treatment modalities varies from country to country and person to person. And in Sri Lanka, when considering literature, there is lacking data we could find regarding acne. So, but still, the acne remains as a significant problem in discuss within our society. Therefore, I was very interested in doing this to describe the awareness of acne and its associated factors, practices, and myths taking university students. And we conducted this study under specific objectives of awareness of acne among the students who are in their early adulthood, and to describe the awareness of associated factors, and to describe the awareness of the methods that they can use to overcome acne, and describe the myths, the beliefs they hold regarding acne. And when come to the methodology part, this is a descriptive cross-sectional study conducted in University of Sri Jayawardenepura, and we took all internal students. The study population was all internal students aged between 20 to 30, and in main 4 faculties in the university: the Faculty of Medicine, Faculty of Commerce, Faculty of Art, and Faculty of Science. And sampling tool we used was an interviewer-administered questionnaire, and sample technique was stratified random sampling method, and sample size was 250 students. We calculate the sample size using IPE statistical package formula there, and sample was selected according to the student ratio from each faculty. And in coming to the data collection analysis, the questionnaire was included 12 main questions under 86 variables were tested, and pre-test was done to 10 students, and the clarifications and modifications of the questionnaire was done, and validity and reliability was also checked, and the final questionnaire was administered to the study population when the students are in their lunch hour during the weekdays. And to fill the questionnaire took less than 10 minutes, and we basically did the questionnaire based on participants' own perception of presence or absence of acne. And then coming to the analysis part, data were entered into Excel sheets, and we used SPS as a statistical program, the 16 version, and from that we did our analysis, including mean, median, standard deviation, and percentages under every and each specific objectives. And results: description of the participants from out of 250 students, most of them are 24 years old. So you can see clearly how the age group is expanded throughout the population study group, and majority of them are females, and majority of the students have acne, which comes to 170 students out of 250. So we can see that it's a very common problem among the students. And when we come to the awareness of acne among the study group, the distribution response for the features that students have identified acne is like this, and there are correct features and the wrong features that we have tested. White hairs, black hairs, papules, and pustules are the correct features. So there's a very good response to that in the students. So they have a good awareness regarding the features of acne, but as well as some students said that rosacea, walls, and skin rashes are also the features of acne. So that is wrong actually. That is the basically identified their lack of knowledge regarding acne. So almost all the like that. And most students have awareness that acne can occur rather than face, like the other body parts also, as neck, chest, and back. And when coming to the awareness of associated factors, basically the main you can see there are the factors, some of the factors that we have put into discuss: the food with fat and oils, cosmetics, dandruff, squeeze in the pimples, lack of sleep, and exams that I have indicated in red color are the responses they have. The most associated with the occurrence of acne that they have indicated. But we thought that in a worldwide, close family relationship also has indicated as an associated factor, but the response for that factor was not as much for our satisfactory, and especially we concerned about that stress, lack of sleep, and exams cause acne in university students. It's a probable thing because they have exams and they are undergoing so many pressures. And awareness methods to overcome acne and treatment modalities they have used. We have identified 4 main methods that they have used very much as a treatment modalities. Wash face twice a day with antibacterial soap or cleanser. Shampooing hair daily or once in 2 days. Avoid touching face with fingers. Avoid squeezing the pimples. So other than that, they have used some other modalities also, but less frequently. And in our country, the homemade paste like sandalwood, aloe vera, that external paste are popular, but we think that is popular, but they have used them in a less degree actually. The response rate was 24.4. And when we come to the myths regarding acne, they hold very strongly that dirty skin and excessive oily skin can cause acne, but it's a multifactorial disorder. We cannot tell exactly that these are the major facts that impact on occurrence of acne. But acne can be prevented by frequent washing of face. They believe that's as a main thing, but dermatologist says that by frequent washing, acne can skin irritate and acne can be exaggerated. And coming to conclusion, most students are aware of the acne and its associated factors, but it's not much so satisfactory. And hygienic practices are good. Washing the face twice a day with antibacterial soap or cleanser, bathing daily, avoid touching and squeezing these pimples that we have identified the most frequent modalities they have used. And home remedies are less frequently they have used. And misconceptions. Even though the undergraduate students, they have misconceptions regarding acne also. And I have recommended that some same type of researchers, community-based researchers and health education programs can be done regarding acne, because it varies. The associated factors, practices and misconception varies from person to person and areas, in various areas. So it is very interesting to see whether there are any other new modalities, new practices that they use regarding acne. So this is what we can do. Like health education tips that we can give to the students based on my research. And thank you. And I like to acknowledge my supervisor, Dr. Tinana Kara, and all the university nursing program staff members contributing to me to conduct this research. And this is my references, some of my references. And thank you so much listening to my research.
Thank you very much, Ms. Veeravardhana, for that interesting paper and addressing a very common and distressing problem among adolescents and young adults. So thank you. And we'll move on to the next presentation. I wonder whether that presenter has arrived. Manuarna is here. Okay. So now, the fourth paper is on healthcare seeking behaviors among students of University of Sri Jayawardhanapura, and the presenting author is Mr. Manu Arana. He is a staff nurse attached to Asiri Group of Hospitals Private Limited. Over to you, Mr. Manu Arana.
Good morning, everybody. This is a study on healthcare seeking behaviors among students of University of Sri Jayawardhanapura. Introduction. Identifying common healthcare services used by the student and factors affecting healthcare seeking behaviors will be of benefit to improve the university healthcare system. There are about 11,000 of students at University of Sri Jayawardhanapura. They are from different socio-economic backgrounds and different religious and cultural backgrounds. University Medical Center is the main health care provider of university students and provides only Western medical treatments during the office hours only. This study will provide data on common healthcare seeking behaviors among students at University of Sri Jayawardhanapura, such as type of treatment and where treatment was obtained. Factors affecting healthcare seeking behaviors: health system factors such as availability of facilities, health status factors like severity of disease, economic and other physical factors, values, religious or cultural factors. Several Sri Lankan studies has assessed healthcare seeking behaviors in different populations as given below. In a study among elderly population in Sri Lanka, 37% had used prescribed Western medicine and 20% had used traditional medicine, while 22% had purchased Western medicine over the counter. A study among flat dwellers in Soisapura in Moratuwa found that people prefer Western health practitioners for their general illnesses. 62% in case of children and 75% of adults. 60% of adults used self-medication as a method of treatment for minor illnesses. Several international studies also assessed healthcare seeking behaviors on young population. A study among university students of Lebanon revealed that when facing health-related issues, the student tended to seek informal health care. Formal health care seeking behaviors was almost non-existent for psychological issues. A study among Ugandan university students showed that accessibility of services was the main barrier faced by students for seek medical care. There was a significant difference in barriers faced by students originally from rural versus peri-urban or urban area in seek medical care. Methodology. This was descriptive cross-sectional survey conducted among undergraduates of the faculties of Humanities and Social Science, Applied Science, Management Studies and Commerce, and Medical Sciences of University of Sri Jawadanapura. Created a sample of 384 students by using simple random sampling method from undergraduates who were willing to participate in the study. Pre-tested self-administered questionnaire consisting of mainly close-ended questions and a few open-ended questions. Questionnaire includes mainly 3 parts: socio-demographic data like age, sex, religious ethnicity, and academic year; common healthcare seeking behaviors such as where obtain treatment and method of treatment. Another part is factors affecting healthcare seeking behaviors: health system factors, health status factors, economic and other physical factors, beliefs, religious or cultural factors. Written informed consent was taken after explaining study by information sheet and consent form. The questionnaire was administered to those who consent to participate without any disturbance to the academic activities. Permission to conduct the research study was obtained from the Vice Chancellor of University of Sri Jawadanapura and Deans of 4 faculties. Ethical clearance was obtained from Ethical Review Committee of Faculty of Medical Sciences, University of Sri Jawadanapura. Privacy and confidentiality of the participant were ensured during all stages of the study. Results. Data analyzed mainly with, as 3 parts: socio-demographic data, common healthcare seeking behaviors, and factors affecting healthcare seeking behaviors. Distribution and gender and income group. Gender distribution, it's 62% of students were female and 38% of students were male. Distribution of monthly income of family income of students, more than about 48% of students had more than 20,000 of monthly income, and also about 28% of students had less than 10,000 of monthly income. Another part is common health care seeking behaviors. Common health conditions among university students. 66% of students had reported depression, and also 44% of students had used home preparation. Frequency of where treatment is obtained. Majority of students, about 71%, had used University Medical Center for obtain their treatment, and 62% help or treatment from friends, parents, teachers, or their trusted persons. Another part is factors affecting healthcare seeking behaviors. Health system factors. Majority of students had concerned about health system factors like availability of facilities, quality of medicine, availability of expert doctors, and also whether their privacy is secured by that treatment method. Health status factors. 78% of students had concern about severity of disease. Students had concern treatment method, how much influence their studies. Then economic and other physical factors. 23% of students had concern on cost of medicine and also 20% about transport facilities and 23% about distance to health care settings. And also 34% of students had reported that they had considered about another factors like their previous experience and also beliefs and myths. Conclusions. Findings shows that there are several kinds of healthcare seeking behaviors among university students. They are different from each other by treatment method and place where treatment was obtained and how they obtain help or treatment. Healthcare seeking behaviors of students are depend on several factors related to their studies, economic background, and cultural factors and their privacy. Recommendations. Research findings will be helpful in conducting healthcare education program to inform the student about common health conditions among university students and education on suitable treatment methods for health conditions and where treatment can be obtained. The research findings can be provided to stakeholders to understand what are the common healthcare seeking behaviors of students and what.
Allergy or hypersensitivity was defined as specifically changed reactivity of a host to an agent on a second or subsequent exposure, and now it is also considered as a damaging reaction. Effects of allergies can vary from minor skin rashes to life-threatening anaphylactic shocks. Anaphylaxis is the most serious outcome of allergies, which is an acute, potentially life-threatening hypersensitivity reaction. An allergy is also one of the serious health conditions that may result in death. Some of the researchers have shown between 150 to 200 people die annually from food allergic reaction or anaphylaxis. According to the Branham and colleagues, from 2003 to 2006, food allergies have resulted in approximately more than 300,000 visits of hospital emergency departments. But in Sri Lanka, the prevalence of allergic disease have not been recorded over time. However, data from other countries have shown that there has been a dramatic rise in allergic diseases in Western countries as well as Southeast Asia and even in Africa. These were my objectives. My general objective was to examine the knowledge and attitude of food and drug allergies among hospitalized adults patients in teaching hospital Karapitiya. And specific objectives were to assess the knowledge regarding common signs and symptoms, practices, treatment, misconceptions of allergies and its association with the socio-demographic status. And second specific objective was to identify the most common allergies among patients in teaching hospital Karapitiya. And the last one was to identify attitudes towards the allergies among patients in teaching hospital Karapitiya. And under my methodology, my aim of the study was to evaluate the level of awareness of the hospitalized adult patient in Galle district regarding allergies. My study design was descriptive cross-sectional study design, and I used the teaching hospital Karapiti as my study setting. And I selected hospitalized adult patient in teaching hospital Karapiti as the population of interest, and I selected 120 people use as the convenient sampling method which contained both open and closed-ended questions. And I used Microsoft Excel 2007 and SPSS 17 package to analyze my data. And these were my results. I wanted to localize their knowledge, so I divided my questions under few subtopics. And first one was to identify the general knowledge on drug and food allergies. So I used 11 questions, and these are some interesting results. Only 50% of the participants knew allergy is a fatal condition, and only 13% said that allergy has no cure. The rest of the participants believed that allergy has a cure. And second one was identifying the allergy specific signs and symptoms. Here I included allergy specific signs and symptoms as well as some other signs and symptoms which are not specific for allergies. So nobody was able to identify all the allergy specific signs and symptoms correctly. More than 90% of participants identified fever, body pains and raised bumps on the skin 1 week after ingestion of the food and drug allergic as allergy specific signs and symptoms. This figure shows how they identified allergy specific signs and symptoms. Most of them, more than 90% of the participants identified itching and raised bumps on the skin immediately after the consumption of food as allergy specific signs. And lowest percentages went for the low blood pressure. And third part was identify major food allergies, because they cause more than 90% of all allergies, all food allergies. So among those food allergens, my participants identified only fish and shellfish by more than 70% of them. And this figure shows how they identified major food allergens. More than 70% of the participants identified fish and shellfish as major food allergens, but I identifying the eggs, wheat and soy and milk as major food allergens was very low. And I included some foods which are not major food allergens and but which are commonly used in Sri Lanka. Pineapple, tomatoes, meat and rice. Pineapple and tomatoes were identified by the more than 90% of the participants, and some of the researchers have shown rice allergy is very common in Japan because they use more rice, but in Sri Lanka also we use rice as a staple food, but in Sri Lanka only 2.5% of the participants identified rice can be an allergen. And identifying major drug allergens, only 11%. I added all major penicillin, aspirin, anticonvulsants, and chemotherapeutic agents as the major drug allergens, as declared by the Food Allergy and Anaphylaxis Network. And only 11% of the patients selected all 4 drugs given as major drug allergens, and 41% of the participants failed to identify at least one as a major food drug allergen. And this figure shows how they identified about major drug allergens. Antibiotics such as penicillin and aspirin were identified by most of them, but the percentage was less than 50. Identifying treatments available. in this study, nobody had heard of epinephrine, adrenaline, even though it is life-saving. Because some other countries, some of the researchers have shown they are using EpiPen, which can be administered by self as a treatment for anaphylaxis. But in Sri Lanka, nobody was identified epinephrine can be used as a life-saving drug. And most of the research findings indicate the knowledge of allergies in people of United States varies significantly among certain groups by sex, annual income, and level of education. At the same time, attitudes are well distributed. However, in my study, I have found that there is no any significant difference of the knowledge with the socio-demographic status, such as age, sex, and level of education and economic level. Allergens could be the more commonest allergies among the study group. Even though the prevalence was not calculated, of these foods and drugs were selected by the most of them as allergens. So about drugs and food could be the commonest allergens among the study group. And attitudes regarding allergies. I used 5 questions regarding attitudes. Most of the people shown positive allergies, positive attitude for allergies. More than 90% of participants pointed out that learning about allergies and how to control allergies is important. At the same time, training programs on the allergies should also be implemented. In conclusion, knowledge on signs and symptoms of allergies was poor. Knowledge on identifying major food and drug allergens and general facts of allergies is not in a satisfactory level when compared to the other countries. Knowledge on treatment methods and preventive measures of all allergies also found to be lacking among Sri Lankan population. Knowledge on availability of emergency treatment for allergies is also poor. Some important misconceptions can be found related to some areas of allergies, such as cure for allergies and some signs and symptoms. And these are my recommendations. The assessment instrument which are needed to quantify the socio-economic impact of the allergic disease should be developed. Prevalence of the allergic disease targeting different populations such as children, adolescents, and adults, and different ethnic groups should be researched. Using a larger sample, prevalence of allergic diseases and their association with the demographic variables should be researched. A proper reporting and documentation system on allergies should be implemented in the hospitals. And I would like to convey my regards to Dr. Perera, Senior Lecturer of the Faculty of Medicine, who guided me from the beginning. And I would like to remind Dr. Nayana Fernando, the Senior Lecturer, Department of Community Medicine, Faculty of Medicine, Krona, for helping me. Thank you very much.
Thank you very much, Mr. Pushpakumara, for that interesting paper. Now, I think we are ahead of time, although we started late. So we have plenty of time for questions and answers from the audience. The panel of speakers will be ready to answer your questions. Can you please put your hand up when you want to ask a question? Identify yourself. Yes. For each. Okay. Yeah, we'll see how it goes, because there may not be anyone, I don't know. Anyway, okay, anyone from, any questions from any of the presenters? Okay. Paper by paper, okay. With regard to the last one then, that is appearing first here, so knowledge and attitude, would you like to come up here? Any questions from Mr. Pushpakumara?
I didn't get the number as one of my as there was not an objective.
That's important, isn't it? Because I
Yes.
mean, these are hospitalized patients. They are already sensitized to allergies, to drugs, to various things. So that taking that sample would be like it's kind of a biased.
I excluded all the people who are related to medical field because they
but-
know about allergies.
Better take from the community, I think. No, community sample will be give a
We had
true
very
reflection.
little time because we were doing our clinical appointment at the same time.
Yeah.
No.
Yeah, and EpiPen is very expensive and it's not available. Hmm? 2.5. Well, another half a minute more for questions from Mr. Pushpakumar. Any questions? 3 minutes then. No? Can we have a mic for the mic?
I
Excuse me.
put some signs.
Can
and
we have a
symptoms
mic
there.
for this?
And I included some signs and symptoms, and I asked them to. I asked if you have seen or if you have heard of these symptoms can be seen after allergies. Please let me know. I did interview administrators.
Right, okay, thank you.
Thank you.
Then we'll, the next paper on diabetic neuropathy, how can we learn to work together? Interprofessional education. Any questions from Ms. Perera?
I must say, I must congratulate her for the choice of this subject. I mean, it's a highly relevant subject and a very innovative approach and something very new to all of us, including medical educators. But I must say, I see a very serious flaw in your methodology in that you said multi-professional and you showed that institution with all the things there. But in your study, you are taking institutions which had only one or two, and you are lumping them all together. So the opportunity for interprofessional education that each of those groups had were totally different to the others. You follow what I mean? Because in Javadanapura, there were 3 groups available. In Kalaniya, there were other groups available.
Yes.
Right, so when you lump the whole together, it is not correct because the opportunity for I must say I am very happy that the highest one came from Javadanapura nursing students.
Yeah.
I can claim some credit for it because when I do clinical teaching, always I include all 3 groups on my ward. You know, if I see students from the ordinary nursing program like that, you see they are joined in that thing.
Yeah.
So the opportunities for interprofessional interaction are totally different in the.
Yes,
It would
sir.
have been very much better if you took one institution.
Yes, sir.
You referred to Chula
Yeah,
sir, you
yeah,
should have
yeah.
taken Chula sir's institution and then
Yes, sir.
looked at it.
This was conducted in 2012 years, sir. At that time, there is not good place to choose. So here and there the students. So this is the first study in Sri Lanka, interprofessional education. As a commencement of this study, we and my the senior lecturers comments, we have to introduce to interprofessional study questionnaire. I know that we have to select the people who are under one roof. So our faculty of Perera, Allied Health Sciences, because they are under one roof. Not here and there places. I believe that's, and I like to, and I wish to do my research as a longitudinal study as well, and the first year, second year, third year, fourth year, how they think about IPE, and final year, what they gain from IPE. And I am planned to do that research also.
Another minute more, I think. Just less than a minute for another question. By the way, the person who asked the question and claimed credit for nursing is Professor Narada Varnasuriya, who was former Vice Chancellor of the Sri Jayawardenepura University. Right, okay, thank you.
Thank you.
Now, the next paper, diabetic neuropathy among the patients in the diabetic clinic, Ms. Nisansala. Any questions from Nisansala?
I just want to check where was the actual nerve reduction studies done, in the Department of Physiology or in the hospital itself?
In the hospitals.
In the hospital.
See, that's why I finalized with the postprandial blood sugar.
Glycosylated hemoglobin
Is the
would have been a
most-
better indicator of adequacy of central arteries than postprandial blood sugar.
Something similar to that. Now, PPBS can be taken from inside, I mean in the clinic itself, very unlikely, or outside. So were you depending on the reports that the patients had with them?
Yes,
And there's always a variability depending on the labs and the timing, which is one of the major problems we have with PPBS.
We have more time for questions from this presenter. In the absence of further questions, we'll move on to the next one. Awareness. Now, which one is associated factors, practices, and myths regarding acne among the students of University of Sri Jayawardenepura, Ms. S.D.P.L. Veeravardhana.
Again, I must congratulate you for a nice conduct study, and you said that it was your perception of whether the student had acne or not, which determined inclusion for the study.
It's a student's perception. I mean, their awareness regarding the features that they think.
The ones that were included for the questionnaire were all people with acne or without acne?
I was targeting all the students, the study population. In the questionnaire, there were wrong features as well as...
No, I saw, but you made a statement that it was your perception whether the student had acne or not, which influenced. You know, that's... So I got the impression that you selected students whom you thought had acne and gave the question.
No, sir, no, actually.
All right. All right. Okay. Then I must say, there was in your conclusions, you had one statement that the commonest age for acne was 24 years. Or something like that.
So that means in my study group, the most amount of students were 24 years of age. I mean, the mean age, the more this.
Presented it wrong because
Yes.
you to decide
Yeah.
what is the commonest age for acne. So, but in the way you presented it gave implication that most of the people with acne were 24 years. So,
Yes, sir. In
No,
the
the mean age.
yes. Yes, sir. In many researchers that they say in some most of the researchers in worldwide that rate of acne occurrence increases at the middle 20s and decreases spontaneously with the age. So I think there's a relation between the mid-age and the acne prevalence because I don't know that the most of the students are in that age in my university. So I think there's a relation between that also. That's very interesting.
24. How do you get that 24?
That's the mean
Yes,
age,
sir.
was it?
Yes.
It was the mean age, I think.
That means I have divided into some groups. I mean, the age groups. The study there was included one factor. I was going to check whether what the age groups the students are included. I mean, 20 to 27 3 and 23 to 25 like that. So.
So, is there anyone else wanting to ask a question? Yeah.
Hostelers.
All universities are.
Because doing a stratified random sampling at lunchtime and getting hold of the students is a bit of a miracle, because when you get the numbers and try to find them, it's one of the most difficult ones. So is that how you did it? Because once you have the numbers, you go by the university name list, correct? And how did you stratify them?
I took the amount of students available in each and every faculty. So I calculated the proportion. So I need 250 students. To according to the proportion, I selected students. Yeah, yes.
But not from a list as such. So 50 students you got from management at different meetings, correct?
Yes, okay, it means. No. No.
No, she said stratified random.
Yes.
Okay, thank you very much.
Thank you.
Then can we ask Mr. Manwarna, healthcare seeking behaviors among students of University of Sri Jayawardhanapura. Any questions from Mr. Manwarna? None from the judge.
Just a suggestion, I think one of the main healthcare seeking behaviors among university students is when they want to get a medical certificate to avoid an assessment. So that didn't figure in your reasons at all, because probably they don't want to divulge that. But that is, did you look into that aspect? That they go to the UMO or something for not necessarily an illness, but with an ulterior motive.
Yes. Usually at exam time for that medical certificate. But I would take that details within 1 month of time. Then
What I'm saying is, you must ask, have you taken a medical certificate from the UMO? Or have you taken a medical certificate from someone else? And so forth. That should be in the study. Even in the KU, we are finding it a major problem. It is a major problem in many universities. Their honors are permitted for people to submit medical certificates for their assessment. Right? So I think when you are studying the healthcare seeking behavior, that aspect also should come into your study. And this
Yeah.
On to the treatment, then relationship and came up with different categories of illnesses, like the physical problems, the psychological problems, and so on. And did you see whether there is any relationship between the type of illness, the underlying illness, and where they have gone for treatment, comparison between the two, depending on the kind of illness and where they have gone?
usually student sought treatment with Western medical treatment for their physical conditions and psychological. When concerning psychological conditions, some of students, about 2%, had sought treatment by Ayurvedic method, local medicine.
Why do you think that is? What's the reason for that, do you think? No, for psychological things, they have been going to the Ayurveda, because the Ayurveda person will take more time talking to the patient.
And also another thing, some maybe psychological conditions manifested by
Physical complaints, yes, correct.
conditions also.
Okay. Counselors. Go to a council.
Might very good for doctor. But I like your study and pattern and things, but I'm just giving you a few suggestions.
Right, okay, now time is up, so yeah. Okay, thank you very much.
Thank you.
Right. Now, as we said at the beginning, this session, the theme is promoting healthcare education and the role of healthcare professionals. So we've had some interesting papers. 3 of them were on studies pertaining to awareness, attitudes, knowledge and practices with regard to acne, with regard to diabetic foot care and food allergies. So I think they were, one person took a sample from undergraduate, from the relevant age group, so undergraduate students. The other one had taken a sample from the diabetic clinic patients, which is quite okay. And the third one was we need to work in teams, in a healthcare team. It's very important in medical care to collaborate together among multi-professional team, in a multi-professional team, so that this would be a start, because when you select the teaching and learning method, then you know what to do and how the students in all these different allied health sciences would learn how to work in a team. So that was interesting and a good start, because we need to reinforce that and strengthen it further, right? So I think that's about, and the acne and the diabetic foot care, they were very good, and I would like you, if you can, to design some health education leaflets or something, maybe in collaboration with the Health Education Bureau, they might help you to devise some health education leaflets for, I think they are already there for diabetic foot care, but for acne I'm not sure whether they have any. I doubt. Are there any? No. So anyway, that's for the future. So I think we can now conclude this session. I would like to conclude by thanking all the speakers and the audience for their participation. Thank you very much. And also the panel of judges and the Dean of the Faculty of Allied Health Sciences. So I'll call them one by one. We'll be awarding certificates to the presenters. So please come up when I call your name. Mr. Pushpakumara.
Could I also please invite Colonel Makulolo to join the podium?
Miss A.D.P. Perera, Miss M.W.N. Nisansala, Miss S.D.P.L. Veeravardhana, Mr. M.H. Manuwarna. Thank you very much, madam. Over to you, Samir.
Okay, thank you very much, everyone. Now I would like to invite Dr. Makulolu again to present the token of appreciation to the chairperson. Thank you, madam. Now, I would like to invite you all to the refreshments which are arranged outside. Thank you.
Thanks. Thank you very much. You did a good job. Thank you. I forgot to thank you, my God.